Good evening, everybody. Welcome to our webinar, New Innovations in Management of Tricuspid Valve Regurgitation, sponsored by the Imaging Council of the American College of Cardiology. My name is Dr. Vera Riggolin. I'm a cardiologist in Chicago at Northwestern Memorial Hospital and Northwestern University, and am the medical director of the echocardiography laboratory and past president of the American Society of Echo. I would like to introduce my co-moderator, Dr. Stephen Little, who is the cardiologist at the Houston Methodist DeBakey Heart and Vascular Center and program director for the Cardiovascular Fellowship at his institution. He's also the director of structural heart for Houston Methodist Hospital System and medical director of the Valve Clinic, and he's also the incoming president of the American Society of Echo. So I'm very honored to have him as my co-moderator. And Steve is going to introduce our other speakers. Steve, I think you're muted.
So that's the only glitch of the night. So thank you for the introduction, Vera, and thank you to the ACC for this introduction, or this opportunity tonight to present great cases on TR. So to introduce the first couple of presenters, first is Dr. Gloria Ayuba, who's at Northwestern, and she's an advanced cardiovascular imaging fellow, and she'll be presenting a case, first case, in just a moment. But before that, Dr. Becky Hahn is going to present sort of a whirlwind tour of tricuspid regurgitation. Dr. Hahn really needs no introduction, but I'll give it a try. She's professor of medicine at Columbia University Medical Center. She's the chief scientific officer for the core lab at the Cardiovascular Research Foundation, and she's director of interventional echocardiography at Columbia Structural Heart and Valve Center.
Okay, additional case presenters are Dr. Lily Zhang, who is a structural imaging fellow at Mount Sinai School of Medicine, and Dr. Tiffany Chen, who is assistant professor of clinical medicine at the Hospital of the University of Pennsylvania.
And I'll introduce our panelists. First is Dr. Colin Barker. Dr. Barker is an associate professor of medicine and director of the Interventional and Structural Cardiology program at Vanderbilt University Medical Center. He's a national leader in percutaneous heart valve therapies and the principal investigator in several clinical trials involving novel therapies for coronary artery disease, heart valve disease, and high blood pressure. He's also a good friend who spent several years with us at Houston Methodist helping to grow and develop our valve program. Our next panelist is Dr. Joao Cavalcante, another good friend. Joao serves as the director of cardiac MRI and structural CT at the Minneapolis Heart Institute Valve Sciences Center, and is director of the Minneapolis Heart Institute Foundation Imaging Research Core Lab. And finally, Dr. Michael Mack, pioneer in the field of cardiovascular surgery and a world-renowned physician. He's the medical director of cardiovascular surgery at Baylor Scott and White Health, and chairman of the Heart Hospital, Plano Research Center. Dr. Mack has performed over 7,000 cardiac surgeries, of which over 3,000 have been valve procedures. So we've got a really esteemed group tonight.
Okay, so if we could have the slides for Dr. Hahn's presentation, she's going to give us a whirlwind tour of the tricuspid valve.
Great, I hope you can see my slides. All right, so this is really going to be a whirlwind tour, so just kind of sit back and take it in. These are my disclosures. I'm going to start with just introducing the fact that tricuspid regurgitation is known to be a risk factor for all-cause mortality. This was a beautiful meta-analysis that looked at 70 different studies and whether or not you adjusted for all the comorbidities that are often seen with tricuspid regurgitation. You could see that tricuspid regurg was associated with an independent predictor of outcomes. And when you look at the indications for intervention, a couple of things kind of pop out at you, and I'm just going to color code them for you. The first is that you really have to understand the etiology of tricuspid regurgitation in order to go through the algorithm. You need to determine the severity of regurgitation and then assess the right heart, not only function but symptoms, and then determine the severity of pulmonary hypertension. So I'm going to take you through each of those steps. Now, the classic classification of TR etiology is to divide it into primary and secondary disease. Primary due to leaflet abnormalities, secondary with normal leaflets and due to support structure abnormalities, which we'll cover in just a minute. These are just some of the examples of primary tricuspid regurgitation, Ebstein's anomaly, which we cannot at this point address with our transcatheter devices, endocarditis, a flail leaflet from a biopsy, carcinoid disease, rheumatic disease. These are all diseases primarily of the leaflets. But when we talk about secondary disease, we want to talk about the support structures for the leaflets, and that includes the papillary muscles and the chordae, as well as the atria and the ventricle. And so we know that the large papillary muscle, the anterior papillary muscle, is the major papillary muscle, supplying chordae to the anterior and the posterior leaflets, and that the septal leaflet has direct chordae to the septum. So you can really get an idea on these two-dimensional short-axis views from the transgastric view, as well as 3D images, the complexity of the chordal apparatus that supports these leaflets. And then tricuspid annular anatomy is super important also. It is a D-shaped structure, it tends to be. There are some multiple crisscrossing muscle attachments directly from the base of the heart, but the annulus itself is not fibrous, except in the anterior portion of near the aortic valve. And so it's really, if you run your finger from the atrium to the ventricle, you can't actually feel a fibrous structure, unlike on the mitral side. We also know that it's saddle-shaped when it's normal, and it loses somewhat the saddle shape, becomes a little bit more round and circular when you have disease processes. And we also know that what's one of the most important things for the right heart is this hinge-like motion of the annulus, because that passively transfers blood from the atrium to the ventricle. So when you lose that longitudinal shortening and that hinge-like motion, then we're a little bit in trouble as far as cardiac output. Denise and Moraro looked at morphology based on three-dimensional echo and showed that when you're dealing with secondary tricuspid regurgitation, that annular dilatation and right atrial dilatation define the severity of the disease. The ventricular functional, so we now know that there are two different types of functional disease. The ventricular functionals have dilatation of the ventricles, which then causes displacement of the papillary muscles and tethering of the tricuspid leaflets, whereas the atrial functional have primarily atrial and annular dilatation with preservation of the RV size and function. And the one area where there's a lot of question is what happens to pacemaker disease. Now, we usually think of it as primary disease because the leaflets tend to be involved, but remember that the leaflets don't have to be involved. It could be subvalvular apparatus. It could be chordal apparatus. It could have perforated the papillary muscle. And so it turns out that we no longer believe cardiac implantable electronic devices should be placed in with secondary or primary disease, but rather its own category. And so the new classification system that's been proposed by the PCR working group in Europe, and I was just privileged to be a part of that group, but it's just a tremendous working group, came up with this proposal, which is that you'll still divide it into secondary and primary disease. CIED gets its own category because indeed you've got, a device in there causing the abnormality, and the abnormality can occur anywhere along the tricuspid apparatus. And so this exact figure will be in a new review article coming out in European Heart Cardiovascular Imaging shortly. So why is it important? Because it turns out that primary and secondary disease have different outcomes. And so we believe that organic or primary disease might overall have maybe slightly better outcomes than valvular or ventricular dysfunction. But indeed, it plays a role in how we determine outcomes for our trials. So the second step is determining TR severity. And how can we accurately do that? Well, it turns out that vena contracta is probably a really bad method because the leaflets are so complex, the regurgitant orifice is complex. We don't think that 7 is going to be the actual cutoff anymore. In addition, we know that it's a very complex valve. It can have 2, 3, 4, 5, 6 leaflets, and therefore the complexity of the regurgitant orifice becomes even more problematic for simple linear dimensions or even for PISA, which assumes a circular orifice. So PISA obviously will underestimate other methods of quantification by 30 to 40%, but PISA is associated with outcomes. So just a smattering of the outcomes using PISA, clearly showing that PISA should continue to be used as one of our more reliable, but not entirely reliable, quantification tools for tricuspid regurgitation, understanding that outcomes will start to be adverse in the moderate range. So we're going to keep our grading scheme just like we have for mitral regurgitation, understand just like with mitral regurgitation that outcomes start to be bad at about 30 millimeters squared. Now, the new method is three-dimensional vena contracta area. This is one of my favorites. Now, the old guidelines from the European ESCVI state that it's still research in the research realm, but it's not. So multiple studies now looking at the correlation between PISA and 3D VCA, showing again that 3D VCA evidence is growing, outcomes associated with it will be forthcoming in some of the trials, and that the PISA underestimates 3D VCA by 40%. So the EuroPCR, again, suggests that we look at hepatic veins. Remember, even though we say it's specific, it's actually not that specific. The original documents actually showed that it was associated with moderate or severe TR. We want to do vena contracta widths. We tend to do averaging orthogonal views. We like to quantify by PISA, and we like to quantify by 3D. But what we've also found is that patients that come to us with severe symptoms of right heart failure have more than severe disease, and so we now have massive torrential disease, suggested by Pepe Zamorano and myself when we were conducting and designing the Triluminate trial. And what we've learned is that indeed multiple authors have now shown the benefit of using an additional grading scheme. These are two authors looking at vena contracta and going to massive and torrential, and these are two authors looking at EROA by PISA, again going to massive and torrential, showing in fact that PISA has a continuous hazard for poor outcomes the higher up you go. And so evidence is associated with outcomes for the extended grading scheme in native tricuspid regurg, and of course also in the trial. So these are early feasibility and compassionate use trials that have all used the extended grading scheme, showing again for edge-to-edge devices, annular devices, that for these trials, a single grade reduction from torrential to massive is associated with improvement in quality of life and functional capacity. And so we do believe that the extended grading scheme is useful, and the current new valvular heart disease guidelines from Europe, as well as the new EACVI valvular heart disease guidelines that are currently in press, both recommend that the extended grading scheme be used for those patients who are considering interventional therapy. Now, we know that we can use multimodality imaging, and so I'm sure that'll be talked about in the forthcoming cases, and so I won't go over that very much, but move on instead to assessment of RV function. Now, when you have this many parameters that you can assess for RV function, then you know that we don't have one really good gold standard right now, and so we can do all of these echocardiographic measures, but remember we also have CMR and 3D echo, which have correlated very well as far as volumes and ejection fraction. And so we do believe also that three-dimensional modalities are going to be the most useful for RV ejection fraction and volumes. What about measuring systolic pressure? Well, we can non-invasively, obviously invasively we can always measure, but non-invasively we can estimate PA pressures using tricuspid regurgitation peak velocities. But remember that the right ventricle is very sensitive to pressure. And so in fact, possibly the best measure of RV function is ventricular arterial coupling. Now, normally that is determined by invasive measures of measuring ventricular elastance and arterial elastance, so EES over EA, but we can actually do it non-invasively. So if we use any measure of RV function on the numerator and any measure of afterload in the denominator, so typically RV systolic pressure, then we can have a non-invasive measure of RV-PA coupling. And it turns out that we now also have studies looking at RV-PA coupling and outcomes, both in native disease, which is the study on the left, and the study that just came out with Mickey Brenner from the TriValve registry showing again that TAPSE predicts outcomes. And the important thing here is that not only does it predict outcomes for native disease and post-TTVR, but that a reduction in RVPA coupling was not associated with poor outcomes, but was rather associated with better survival. And so we're beginning to learn how the interaction between RV and pulmonary artery can predict outcomes. Now, what do we have for intervention is isolated surgery. If you don't do it at the time of left ventricular surgery, then you have to do it as isolated. And so we now know, and this comes out of France, confirming the studies that also came out of the U.S., that there's about a 10% mortality associated with isolated tricuspid valve surgery. And part of that reason is that they come too late. They have much higher New York Heart Association class. They have moderate to severe RV dysfunction and symptoms of right heart failure. Those are all poor prognostic signs and signs that we operate too late on these patients. And so that study came up with a beautiful scoring system, TriScore, which is all available online. And we've put our patients on there frequently to just show the patients their risk for mortality. And it's pretty rare to have it under 12% mortality, and not infrequent that some of the patients that we see coming to intervention have a mortality and an in-hospital risk of dying of about 30 to 40%. So it's pretty terrible at this particular time that we have to get to these patients earlier. And so to get to the patients earlier and to maybe have lower mortality, we think that transcatheter solutions will be where we need to go. And currently, Europe has 4 devices that are already approved, 2 of the leaflet coaptation devices, an annular device, and a heterotopic valve replacement device. So no orthotopic valve replacement yet for Europe. And the real question are who the appropriate patients are for the particular therapy, what anatomy is suitable, and can we improve outcomes. And toward that end, we have a number of randomized trials now ongoing in order to answer those questions. But the questions as far as which device will remain as we begin to learn about the limitations of each of these devices. And so there's chordal variability and leaflet variability. 2 studies now showing that the more complex the leaflet morphology, the worse the ability to reduce tricuspid regurgitation. We also know that gap size is going to be limited for the leaflet edge-to-edge devices, and that pacemakers are a no-no. If the pacemaker is indeed causing the tricuspid regurg, you're not going to get a good result. And then finally, imaging becomes quite difficult when you're trying to image that thin tricuspid valve leaflet. The annular devices have a lot of problems. Remember, the annulus is not fibrous, so there's lots of issues with dehiscence of the devices. And in addition, we know anatomically that those patients with a lot of tethering, this patient had a transcatheter annular device and there's still severe tricuspid regurg. That if you have a lot of tethering, an annular device may not be the appropriate therapy. And indeed, again, the annular devices are difficult to image. That was a 2D ICE image of us implanting a millipede device. And so a lot of other challenges for the heterotopic valves as well, but where many of the trials are going is valve replacement. Here again, we don't have a lot of the answers as far as what happens to the right ventricle. We know that pre-existing pacemakers are not an issue, but new pacemakers might be, and that thrombosis and valve durability will plague us just as it does in all the other valve spaces. So the future goals for the heart team is to increase the awareness, just like we are doing now through the ACC Imaging Council, and I cannot thank you enough for the invitation. Improve the quantification tools important for determining outcomes, determine the most appropriate management strategies and appropriate intervention, and importantly, determine what outcomes are really meaningful. And here's where the patient comes in, because in tricuspid regurgitation, what we found is that all patients feel better, even if you reduce the regurg by just 1 grade. And so it's time for TVARC, and I welcome any questions. Thanks for your attention.
Thank you, Becky. That truly was a whirlwind and a ton of information in a very short period of time. So thank you for that. And while Dr. Ayuba gets her slides up, if she could go ahead and share her slides. There was a question that came through the chat asking about atrial functional TR and whether the burden of AFib influences the severity of TR and the degree of functional TR that you see.
Well, I mean, I can answer that, but yes, it does. So most of the atrial functionals have atrial fibrillation. They're the ones that end up having marked dilatation of the atria and the annulus. And so they form the bulk of the patients that we see with atrial functional disease, but we can also see it with just HFpEF. So anything that increases the pressure coming back toward the right ventricle can sometimes also be associated with atrial functional instead of ventricular functional. The ones that have ventricular functional, the worst ventricular functional, are the arterial pulmonary hypertension patients, so the precapillary pulmonary hypertension.
But the question was, does the burden of AFib seem to
Definitely.
influence the severity of
Yeah, no
TR?
question. Atrial fibrillation ends up causing atrial dilatation, which ends up causing atrial functional disease. And where the U.S. and European guidelines have gone is to consider rhythm, not rate control, but rhythm control, which I completely agree with. I think that, you know, we battle those early studies that showed that we could do rate control and that would be okay. But in my mind, it needs to be rhythm control in order to avoid TR.
Great. Thank you so much for that. Dr. Yayuba, you can put your slides into presentation mode and then take it away.
All right, so let's dive a little bit into some treatment strategies, and I'll be talking about the first case here. And I have no relevant disclosures. So the first case is that of a 70-year-old female with a complaint of dyspnea and reduced exercise capacity. NYHA class 3 symptoms. She's got significant comorbidities, including coronary artery disease, history of an MI requiring PCI, long-standing history of paroxysmal atrial fibrillation, and a prior SVT that required ablation. She underwent a right heart cath that showed mild pulmonary hypertension and underwent a subsequent TEE, which showed significant amount of tricuspid regurgitation that appeared central in origin. And in the transgastric views, we can appreciate again a significant amount of tricuspid regurgitation that is due to malcoaptation of the leaflets. So pulling your probe back a little bit into the deep esophageal views, you can better appreciate the anatomy of the tricuspid valve leaflets here with malcoaptation of the leaflet tips and a central regurgitant jet that is likely primarily being driven by annular dilatation with an annulus that's measured at about 4.3 centimeters. So from a grading standpoint of her tricuspid regurgitation, she was determined to have torrential tricuspid regurgitation by quantitative assessment with a VCA and with a regurgitant volume of about 110 mLs. From a right ventricular function standpoint, her right ventricular function indices were within normal limits with a slight reduction in her right ventricular myocardial mechanics with her RV strain measured at about 18%. I'm going to pause here for a brief discussion.
So let's go ahead and we'll ask the panelists. So we've seen a great case, a fairly typical case that is being, presenting to many of the sort of level 1 valve centers. So we've got a symptomatic patient with torrential TR, and these are the RV functional indices in front of you. So maybe Dr. Barker, we'll start with you. Sort of with all that, this patient walks into your valve clinic. What are sort of the range of possible therapies that you're considering for this sort of patient?
So we generally lay out 4 options. Surgical repair or replacement is one. Participation in a clinical trial is either repair or replacement, transcatheter, transfemoral, transvenous, or what ends up being our kind of most popular or most common decision is an off-label mitral clip. And we did a case almost identical to this yesterday, but I'll hold off and see what the others think.
All right. Dr. Mack, what would you think? You're our surgeon. Is this somebody that you would consider surgery on?
So, absolutely, Steve. And I agree with Colin that there are basically 4 options here. Our results with surgery are actually pretty good, much better than what Becky quoted. The mortality is 2 to 3%, but one is because we're highly selective in terms of who we do. And then we also prehab the patients if they have RV dysfunction. and that means preoperative milrinone, et cetera. However, having said that, now that we have all these less invasive options, those become our preferential approach. So in somebody like this who has preserved RV function, but significant annular dilatation and huge coaptation gap, this patient would be a candidate either for a transcatheter annuloplasty or a transcatheter replacement. Failing qualification for one of those trials, we would then opt for surgery. I don't think that this patient's a good MitraClip candidate because of the gap between the leaflets. The other issue here is this annulus is so large that it may not be a good candidate for any of the transcatheter replacement trials because the devices just aren't big enough. If you have an exclusion from the trials, it's usually because the annulus is too large.
Perfect, thank you. Well, in the sake of time, we'll come back to the panelists maybe after this case where we hear some more from Dr. Ayuba.
Okay, so following a heart team discussion, a decision was subsequently made for percutaneous annuloplasty device, and the patient was subsequently enrolled in the Cardioband early feasibility studies. So the Cardioband system is a percutaneous polyester band that is fixated along the tricuspid annulus from the anteroseptal commissure to the posteroseptal commissure using 6 millimeter long anchor screws. And after the anchor has been deployed, this cardioband can be cinched, sort of contracting the annulus, improving coaptation of the tricuspid valve leaflets, and in so doing, reduce the severity of tricuspid regurgitation. CT plays an important role in regards to device sizing, and this is done by measuring the perimeter from the anteroseptal to the posteroseptal commissure, with the maximum device length being available being 128 millimeters for the studies. CT also plays an important role in determining the course of the RCA relative to the tricuspid annulus, ensuring, of course, that you have enough of a distance from the RCA to the tricuspid leaflet insertions. This can be determined at various phases of the cardiac cycle, and it allows us to determine what the optimal anchoring targets would be, and to determine if there's any unfavorable course of the RCA with a distance of 2 millimeters or less from the tricuspid annulus being unfavorable. The patient subsequently had the Cardioband system implanted. Using biplane imaging here, we are able to ensure that the screws are being implanted at the level of the annulus and not the leaflets. And 3D MPR also plays an important role in this, where you're able to sort of have a short axis view of the tricuspid valve to kind of determine where exactly the anchors are being placed. Following device deployment, we subsequently cinched the device and ended at a 5.5 level of cinching with significant reduction in the severity of tricuspid regurgitation. So comparing her pre-procedural images on the left to the post-procedural images on the right, you can appreciate contraction of the annulus, significant reduction in the regurgitation that you can visualize, and improvement of her regurgitant volume from 110 mLs to about 16 mLs, of course, with also septolateral diameter reduction. At the end of the procedure, we take a look at the RCA, and no damage was done. At 6 months follow-up, patient had completed cardiac rehab. She had no hospitalizations at that time. Her symptoms had improved to an NYHA class 1, and she was walking up to 2 miles a day. So in summary, echo plays an important role not only in defining the severity and the mechanisms of TR, but also in determining who's a favorable or unfavorable candidate for this procedure. CT is also important in device sizing and assessing if there's any tricuspid annular calcification and the proximity of the RCA. And the procedure is typically guided by fluoroscopy and 2-dimensional and 3-dimensional imaging. Thank you.
Terrific. So as was recommended by the panel, a primary annular intervention that got to a very nice result. In the interest of time, we're going to ask Dr. Zhang to go ahead and upload her slides, or not upload them, to access them. And while that's happening, Dr. Cavalcante, maybe you can just give us a comment on sort of how you see the utility of CT and some of the planning for these sorts of procedures.
It's a fantastic question. Thanks, Steve, and all the panels here. Great results, great case, challenging anatomy, and then spot on, comments by Dr. Mack. I mean, is it wide gaps that would be difficult for edge-to-edge repair, even though the annulus was dilated too, is still approachable for a cardioband. Combo procedures have been done too. So you do annuloplasty that facilitates an edge-to-edge repair, but obviously we're not promoting that. The CT plays an important role not only for the anatomical planning, but also I would say functional evaluation. So with CT, we can look at how big is the RV, how remodeling, how good is the function, along with many other aspects as well, morphology of the leaflets, and even TR quantification by measuring the anatomical regurgitant orifice area.
Thanks, Joel.
Mm-hmm.
Dr. Zhang, you ready to go?
Hello, can everyone hear me? Oh,
Yes.
okay, I will go ahead and share my slides. Okay, thank you for inviting me to give the second case presentation. The title is Not Your Everyday Tricuspid Valve. With an 80-year-old female with a history of quote-unquote history heart failure with preserved EF, atrial fibrillation, who presented with 3 weeks of shortness of breath, weakness, and lower extremity edema. She had a past medical history of recurrent pleural effusions requiring thoracentesis and 2 heart failure admissions in the past year at hospitals. On physical exam, she had very small body weight, BSA 1.5, appeared very frail and fatigued, hypoxia, and other physical signs of right heart failure, elevated ELK phos and BNP. On surface echo, you can appreciate that she has a massively dilated right ventricle, small LV and normal function, dilated coronary sinus consistent with chronically elevated right atrial pressure. Other views of the RV inflow and apical view, you can appreciate that her tricuspid leaflet tips have a wide gap with non-coaptation and what appears to be torrential tricuspid regurgitation. Subcausal view, again, you can see how wide the gap is, and marked systolic flow reversal in hepatic veins. This is a depiction of a 3D imaging on her surface echo, actually. And you start to look at the valve, and it may not be really 3 leaflets per se. Other quantitative measures by 3D planimetry, the non-coaptation orifice area was about 1.3 centimeters squared, and using PISA, we also come up with about 1.24 centimeters squared of non-coaptation area. Other measures show that she has low output state of LVOT, VTI only 13 centimeters, and other valves were mildly regurgitant. Transesophageal echo showed similar findings of RV dilation and leaflet non-coaptation, so I won't belabor on that, but the transgastric view showed ELK of her so-called tricuspid valve to really have more than just 3 leaflets, and you can see that the non-coaptation area assumes a 5-pronged star shape. RV strain, sorry. We got a free wall strain of about 17% and including the septal strain 16%. Cardiac CT again shows maximally dilated RV and low stroke volumes of in the low to mid 40 cc's and regurgitation volume of 64 cc's. Right heart cath shows relatively normal Wood pressure and minimally elevated peer pressure with PVR about 3.3 Wood units in the setting with very low cardiac output index of 1.9. She was optimized discharge with diuretics and digoxin, but quickly returned with this similar presentation. So I will pause here for comments.
Thank you, Dr. Zhang, for that great presentation. You nicely demonstrated a lot of different quantitative methods to assess the severity of TR. Dr. Han, if you're still on, I'd like your comments about, you mentioned a little bit in your presentation about all the different methodologies that we have to assess TR severity by echo. Do you have a preferred method or a method that, or how do you choose what to do in what patient, and what do you think is the best for a patient
Well,
like this in terms of
we do.
modification?
Yeah, I mean, thanks for the question. We do have different cutoffs for use of each of the modalities because we know that PISA underestimates the other two. In our core lab, we've been able to show, and this was published already, that the 3D VCA and quantitative Doppler, so we've devised the protocol for performing quantitative Doppler on the tricuspid valve, which is, got a very elliptical annulus, so we have to use a biplane view. But that those two correlate really, really well. The correlation is about 0.89, so they correlate very well, and that PISA will underestimate both of those by about 40 to 50% in our core lab. And so we use them all, but we have different cutoffs for each one. My favorite is still going to be 3D VCA because it's fast, but I think the more accurate is going to be the quantitative Doppler done correctly. We all do PISA because we have outcomes associated with PISA.
Okay, wonderful. And then there's a question on the chat maybe that you can answer while you're on. Is there a website or a place where people listening can look for sites that have ongoing tricuspid valve intervention trials and some advice on where to refer patients?
Yeah, the CT Surgery Network, not CT Surgery, I'm sorry, the clinicaltrials.gov usually has the, if you're looking for the trials, usually has the sites. Mike may know more as well, but usually has the sites that are participating in those trials. Obviously, if you go on to individual device websites, like, Edwards has two different randomized trials going on. Abbott has the Triluminate randomized trial going on. They will also, I think, give you sites that are currently enrolling in the trials. There's up to 85 sites enrolling in some of these trials, so there's a lot of them around the country.
Wonderful, thank you. Okay, for the sake of time, why don't we have Dr. Zhang tell us what they ended up doing with this patient.
Okay, so because of her, frailty and old age, we decided to give her compassionate edge-to-edge repair in attempt. So we also decided, because of her difficult non-tricuspid anatomy, to use intracardiac echo to assist with the procedure. So this is the transesophageal echo on the day of the procedure, again with non-coefficient area of about 1.2 centimeters square. And this is the depiction of the ICE catheter showing the leaflets pretty well seen in both systole and diastole. This is a live 3D capability catheter, so you can see on biplane, this is live color Doppler, very well displayed. So we're going in with the first clip, attempting to snatch the septal in the interior leaflet, and here you have in comparison ICE images. And this is the fluoroscopic image of the ICE catheter seen on top of the tricuspid apparatus. Keep in mind there are about over 800 elements in this tiny, a few millimeter wide catheter, and for a live 3D TE probe, there are over 3,000 elements. So given these restrictions, the images are extremely good, I would say. And we're going in with the second clip side by side to each other. Again, T on the left and the ICE on the right for comparison. And we have, again, NPR from the T and the biplane color Doppler with the second clip deployed. And now finally, the third clip has been deployed, and you can see a marked reduction in the severity of the tricuspid regurgitation. There's a couple of small residual jets in between the second and the third clip displayed on both ICE and TC. And finally, transgastric view. I think there is a very nice reduction of the TR severity. And this is also supported by the fact that the ICE catheter was able to capture a PW of the hepatic vein, and you can see almost complete resolution of that systolic flow reversal. And finally, I tried to planimeter what's remained, and the total ERO is about 0.3. And recall, we started with the 1.2 to 1.3 centimeters squared. Next day transthoracic shows that the TR is about the same, and the clips are stable. However, her peak TR velocity on the next day was about 3.7 meters per second, which gives you a systolic peer pressure in the 60s range, assuming her mean peer pressure is of 10. The good news is that her cardiac output by this calculation has increased to 4.5 liters as opposed to 2.7 in the beginning. And you can see there's some septal bulging during systole into the LV, suggestive of RV pressure overload. And as far as strain, expectedly it decreased after the procedure from 17% now down to 12%. So taking all this data together, we have a RV PA coupling ratio, or if you will, in this case, uncoupling ratio of 0.2% per millimeters of mercury. And Dr. Hahn already showed this data. So based on her classification, we believe that our patient has this very rare type of the type 4, that's only 5% of the population, where you have A1, A2, P1, P2, and septal leaflet. So in conclusion, ICE with 3D live capability for excellent supplemental imaging to TE, especially if you have difficult anatomy and adjacent acoustic shadowing. And RV function is expected to decrease after substantial reduction of the tricuspid regurgitation. RV-PA coupling may be a good, useful predictor of future clinical outcomes. Thank you.
Thank you, Dr. Zhang. That was a lot of really great information, and really brings up a lot of really interesting points about the right ventricle. And even though we're focused on the tricuspid valve is connected to the right ventricle, and so it's an important structure for us to keep in mind. Maybe I can ask Dr. Barker and Dr. Mack, how do you assess RV function before undergoing a tricuspid valve procedure? Is there a specific method that you feel is best to assess RV function? And is there a parameter that you think it defines a patient that's too late and that you would not proceed with a tricuspid valve intervention?
I think we do struggle with that, and it's one of those things that it's sometimes hard to quantify, but when you see it, you know what you're dealing with. But I was really impressed. I guess, Becky, is he one of your fellows, Mickey Brenner, who showed this TAPC, PA, this coupling data?
Yeah.
And that seemed to be pretty powerful. So I've started looking at that. I don't know if I should be, but
Yeah.
it seems like that's a really good way to predict who might, how people are going to respond.
Yeah, I mean, I think you're right. That Mickey Brenner is one of our fellows, so he's now published quite a lot already on RVPA coupling, including the results of RVPA coupling for the COAP trial. But for the the TriValve registry, it's just so interesting. We don't really understand all of it yet, Colin, because in that registry it showed that, and other studies have also shown that once you take away the tricuspid regurg and you increase afterload, you actually can uncouple. I mean, your RVPA coupling can get worse, but in that study, it predicted a better outcome. And again, probably both a combination of having enough contractile reserve. So even though you have a drop in RV function, you have enough reserve, but also what other studies have shown, and we suspect is also true, is that as you, even though you have a reduction in total stroke volume of the RV, you improve your forward stroke volume and thereby increase your PI pressures. And that's why the RV-PI coupling looks like it's getting worse, but it's an indication of increase in forward flow. And that's been shown actually by CMR. So the group out of Leipzig under Philip Lurtz has actually shown by CMR that you'll see a drop in total RV stroke volume with an increase in forward stroke volume. So it's really something that we're still learning about, and we're hoping that it's a good measure that we can use.
So I know we're behind on time, so I'll make the comments brief. I think the message here is you can't look at the TR in isolation. You have to look at three things. You have to look at the TR, you have to look at the right ventricular function, and you have to look at the pulmonary artery pressure. If your right ventricle's too gone, it doesn't matter how good a job you do in terms of fixing the TR. That patient's not going to do well and not going to get better. And I think you look at RV ejection fraction. I think in this patient was 43%. So despite the fact it was so dilated, the ejection fraction was well preserved. You look at global longitudinal strain, which I think is an important part of it. And you look at TAPSE. One of the things to remember with TAPSE, a lot of these patients have had previous bypass surgery. And if you don't have an intact pericardium, your TAPSE is not accurate. So you have to take that into consideration. And then the last is you may have to look at whether it's pre-capillary pulmonary hypertension or not and whether it's reversible. And indeed, in this case, Lily showed that I think the pulmonary vascular resistance was 3.3 Wood units. So that's good, you know. And you also have to make sure that left-sided disease is fixed so that, you can't expect a good result in the face of unfixed post-capillary hypertension due to residual left-sided disease.
Excellent points. Thank you both. Well, we'll keep moving in the interest of time on to our third and final case. Dr. Chen from UPenn, if she can pull up her slides.
All right, good evening, everyone. Hopefully you can see my slides. So in the next few minutes, I'll just present another brief case that'll serve as platform for some discussion. So these are my disclosures. So the patient we have is an 87-year-old woman who's quite vigorous. She has some exertional dyspnea, but was recently golfing, enjoyed doing water aerobics, but recently has been having trouble walking up a single flight of stairs. She also has a chronic persistent AFib, failed cardioversions many years ago, HFpEF, hypertension, and some degree of atrial functional mitral regurgitation as well. She's on a loop diuretic, on apixaban for her atrial fibrillation, beta blocker, ARB and hydralazine for hypertension. And here you see her STS score calculated for mitral valve repair. So as for many of these patients, they start with a transthoracic echo, and what we see here is that she has a small ventricle, small left ventricle, and preserved ejection fraction. However, her RV does appear to be somewhat hypokinetic with a mildly borderline reduced TAPSE, RVS prime, and RV free wall longitudinal strain. PASP was 55 on this echo, and in the bottom right here you see one image of the tricuspid regurgitation by color Doppler with already you can see there is a sizable central coaptation gap. So moving on, the patient subsequently had a transesophageal echo, and here you see some of the representative images in which in the transgastric short axis view you see the leaflet anatomy defined quite well, and there might be 4 leaflets in this particular example, and a large coaptation gap with a lot of TR, and this top right view shows sort of a commissural view with biplane imaging showing the TR jet. And with 3D vena contracta area, as mentioned before, we're able to get some quantitative data. And here hers was 0.91. She also had systolic flow reversal in the hepatic veins. And also with 3D live NPR, we can also simulate or create long axis views as well as a non-FOSS view of the tricuspid valve. So she also had a cardiac MRI because there was some concern of a restrictive cardiomyopathy. So at some point she did undergo CMR, and what you see in the top right here is that there are dephasing jets corresponding to tricuspid regurgitation. However, we do need to do phase contrast velocity encoding flow mapping to be able to actually quantify the TR, which is done by an indirect method, both with phase contrast imaging as well as with the RV volumes on the short axis cine stack that you see here. So with that, what was notable was that her RV size was only 109 milliliters, and this is total, this is not index. She's a quite small RV, preserved RVEF, and low stroke volumes. There was no shunt detected, and there was no delayed enhancement. Parametric mapping was not done on this outside scan. And here's her tricuspid regurgitation. It quantified to a regurgitation volume of only 28, but given her sort of low output state, translated to a regurgitant fraction of 47%. In terms of further imaging, she had a cardiac CT, more for procedural planning. At this point, percutaneous therapy was considered. And so on this, it's a retrospective gated CT, so we can assess for volumes, function, and particularly we could look at the subvalvular apparatus a little bit better than by echo. And what we see here again is a large central coaptation gap, and we can segment the annulus with a number of software tools, but grossly you see that her annular dimensions translate to an average diameter of around 43 millimeters. So in addition to sort of this anatomic information that we can garner from CT, we can also get a lot of information specific to procedural planning depending on the device that is being considered. And these include fluoroscopic angles for coplanar angles and distances to leads, right coronary artery. You can look at the IVC to RA angulation and even simulate certain delivery sheets and catheters. Or do 3D printing from these CT data sets. So in terms of clinical course, the patient was enrolled in the Tricuspid early feasibility study. She underwent successful implant of a 44 millimeter Evoke device, and you see what the device looks like when it's implanted. She did quite well. She was able to go back to water aerobics and was doing well at 6 months follow-up. So lastly, I just want to go over some of the data that was presented at ACC last year by Dr. Kodali on the early results of the Tricuspid early feasibility study at 30 days. What you see is that this is about 56 patients. Vast majority had severe or greater TR, 92% of them. Many of them had atrial fibrillation. And how did they do? There was 94% procedural success with marked improvement in symptoms and functional capacity based on NYHA class, 6-minute walk test, and KCCQ score, and low incidence of major adverse events. And some of the imaging data show that there was dramatic reduction in tricuspid regurgitation, such that 98% had none to mild at 30 days. So that's all I have. And I'd like to thank you for your attention and welcome any comments and discussion.
Thank you, Dr. Chen. Great case. I'll go ahead and ask a panel question. Dr. Mack, you first. So this is a phenomenal case of TTVR, the first one we've seen this evening anyway. Why has this taken so long? Why has it taken so long to get from TAVR to the tricuspid valve? What are some maybe the anatomic challenges? That's the first question. And then as a part two to that question, 5 years from now, what's going to be our dominant therapy?
So a couple of things, Steve. I think it's taken so long to get from TAVR to tricuspid because mitral got in the way. And mitral has slowed everything down. It's been much more difficult, the trials, than anybody thought. You know, the tricuspid valve has euphemistically been called over the years the forgotten valve, and it's only recently become unforgotten. A couple other thoughts. You know, one is it's no accident that the 3 cases presented this evening were females. because this is a disease of females. About 75% of patients in our surgical experience and in the trials are females. Secondly, the symptoms are so insidious, and it's, you know, it's amazing the quality of life issues that only become apparent after it's fixed. So there is an underdiagnosis, under-recognition, and then because of the invasive nature of surgery, an under-referral for treatment. I think that tricuspid is going to get approval and adoption much quicker than mitral. 3 of the devices you heard are likely going to be approved early next year. So that I think that we will see a much more rapid adoption of it. Right now, I think if I had to make a guess, it'll be equally split between edge to edge and replacement. Replacement looks surprisingly good, and it's easier on the right side than it is on the left side. The most valuable player of those procedures is the imager. I would view that as the quarterback, and the operator is just a knobologist. We did 2 TriSens on Monday, and it took us 40 minutes each, you know, for the procedure. So I think in the short term, replacement's going to look very, very attractive, but I'm sure the other shoe hasn't dropped yet, and the anticoagulation, thrombosis, durability issues may rear its head a couple years down the line.
May I make a quick comment too? I think that it's quite also surprising that all these patients had chronic atrial fibrillation, and that's 70-80% of the population we treat. I think the other group, and a suggestion for a future webinar, would be to bring the EP, the electrophysiologists, because they see these patients probably much earlier than what we see as imagers. As important to educate the imaging community is also for them to recognize that TR exists and might be treatable. You know, and we have to diagnose, obviously, and recognize the TR that is lead induced, and there is TR that has nothing to do with the lead, and the lead is just circulating. And by removing that lead might not do anything other than harm to the patient. So we're starting to recognize also there are other categories for these patients, and I think involving EP will go a long way to go upstream.
Great comments. Thank you, Joel. I was going to come to you with a question anyway, so since you're still on the big screen, I'll ask it. This is presented by the Imaging Council of the ACC. So, you know, you and Becky are the panel imagers. So training to learn how to do all this stuff. CT training, MRI training, TE training. I mean, there's obviously lots of hurdles. What do you see as the priorities to get imagers ready for this avalanche of intervention that we're all sort of expecting?
We have other opinions here too, but I would just say, as Dr. Mack mentioned, these procedures, you talk about TEER, you talk about the right side as well, cannot be done without an imager. Yet the reimbursement, as you highlighted a couple weeks ago, Steve, it's completely out of proportion to the skills necessary, not only for the training, but for the guidance and the time that it takes. I think we have to be creative because this is not yet a subspecialty. We are being called by most centers as by what we don't do. We are considered non-invasive imagers. I guess I could be a non-EP person or a non-heart failure. Call us for what we do. Call us as an imager because I think that requires a specific training. With that recognition, what allows us to also go to industry and be creative, get some funding, not for structural imagers, for structural interventionalists. We're training many more structural interventionalists than structural imagers. And we will need to match and close that gap. Otherwise, you know, it's going to de-incentivize interested fellows that wanted to get into that field, but it becomes quite difficult to be, you know, sustainable.
Thanks, Joel. Becky, same question.
Yeah, no, I think the societies and American Society of Echo is obviously very strongly behind the training documents that need to be designed, and obviously I'm also part of the multimodality ACC endeavor to write training guidelines. So All of these things are in the works because it's really been recognized that structural imagers need extra training. I mean, you're just not going to get it typically in a 2 or 3 year fellowship, and so those documents are in the works. I think Vera should speak about that if she wouldn't mind. But I do think that we have societal backing from the imaging societies to the college, and that's what it's going to take to really change the minds of our administrators and institutions, who then have to then also back it up with the appropriate compensation.
Thank you, Becky.
Dr.
And
Mack.
as you know,
Yeah, so Steve, if I could just weigh in there. So I am one of those administrators, and we do have to subsidize our imaging interventionalists, and it's money well spent. So each of you, until reimbursement changes, institutions need to expect to support the time spent by interventional imagers because otherwise it doesn't work.
Vera, maybe the last word, given the time, comes from Dr. Riggleman.
Yeah. No, I think that this has been a really great discussion and lots of issues that we don't have full answers for. But in terms of training, we are working on it. We are working on coming up with guidelines to train fellows as well as individuals who have already completed fellowship, since many of these interventional structural heart programs are beginning in programs that don't have fellows. So it's important to train individuals who have finished practice or finished their training already. So we are working on some guidance for that as well. So stay tuned. Thank you. I want to thank all of the panel as well as our case presenters for a really fantastic discussion and overview of the complexities of tricuspid valve disease. And even though the tricuspid valve was formerly known as the forgotten valve, hopefully after this webinar we realize that it's not forgotten. So with that, I want to thank everybody and have a wonderful evening.